Our next speaker is the second of the Ruane Prize speakers. He's not the second, actually, they're equal. He's just another of the Ruane Prize people, Chris McDougall. Chris McDougall comes to us here as the director of the Lurie Autism Center at Mass General and at the Mass General Hospital for Children. At Harvard, he's the Nancy Lurie Marks Professor of Psychiatry, and he's an associate member of the Center for Human Genetic Research at Mass General. I think I got all of his associates. I can tell you a little bit about where Dr. McDougall was educated, and it wasn't WashU, so it's a little currently refreshing. He started out with his BA degree at Valparaiso University, which is in Indiana. Then he went to the University of Indiana for his MD degree, and then off to a psychiatry residency at Yale. As oftentimes happens at Yale, he wound up staying there for some period of time after his residency, and he spent much time at the Yale Child Study Center and did a lot of his early research there. In 1997, he was recruited back to the University of Indiana to be chair of psychiatry and to be a general mentor, teacher, and scientist there. And then in 2011 was when he made the move to Mass General, where he is now. His Dr. McDougall's scholarly activities revolve around research in autism, and I'm sure we'll hear a lot about that today. He's done a lot of teaching and a lot of supervising. He does academic psychiatry in a very usual way. Not usual because he's very unusual. He's what I think of as a consummate academic scholar, publisher and scholar. He publishes on autism and other childhood disorders. He's done genetics and he's done molecular psychiatry and treatment. And he's particularly a mentor to many people in the field. Dr. McDougall's talk is the psychopharmacology of childhood onset neuropsychiatric disorders across the lifespan. Dr. McDougall.
Thank you. Well, thanks, Dr. Tabinga, for the nice introduction, and thanks to BBRF for the award and opportunity, and thanks to all of you for coming today. So I'm going to talk a lot today about repetitive thoughts and repetitive behaviors, which really underlies most of the research I've done throughout my career. The first half of my career was focused on adults with OCD, and I'm going to talk a lot about that. Certainly there are repetitive thoughts in OCD, obsessions, and compulsions. Then I met a patient halfway through my career, and I decided I would change my career based on meeting one patient. So I said I'm going to do autism now. And there are also repetitive thoughts and behaviors in people with autism. Many people would say they have OCD. They don't have OCD. So not everything that's repetitive is OCD. And treatment is very different in the two different conditions. So I hope to convince you of that. So this slide gets your attention. You know, there are these perfumes and colognes for women and men and obsession. But this right away, this tells you people out in the real world, like some of you, use this term incorrectly. So when the guys on Madison Avenue make these products, they want to sell them, right? And why would they call them obsession? Well, it's you have a certain thought about a person, you're attracted to them. It's a pleasurable experience, but that's not what an obsession is. So this is not named correctly. And at the end of the talk, I'm going to ask you which of the 5 possible repetitive thoughts this should have been called. So these are the repetitive thoughts that I think exist. And I'm going to start by talking about obsessions, because I'm going to talk about OCD. So an obsession is ego dystonic. That means it doesn't feel good when you think about it. It bothers you. You don't want it in your mind. You try to push it out of your mind. So when you guys say you're obsessed with Real Housewives of whatever, you're not obsessed. You're drawn to it. You want to watch it. And people with OCD, they have these intrusive thoughts. They know that they don't make sense. I know this doesn't make sense, but I can't keep the thoughts out of my mind. So they might feel that their hands are contaminated. And if they shake hands, they're going to pass a disease throughout the world. They know that that's not true, but they can't stop thinking about it, and it's very distressing. So compulsion is the behavioral parallel to an obsession in people with OCD. And these are the different types of repetitive behavior. The term tic is misused in society all the time. I'm not blaming anybody, but I'm just trying to educate people. So we'll talk about compulsion. So a compulsion is voluntary. You initiate the action to clean or check things, check the door. You do it purposely. It's something people do normally in the world as well. But if you have OCD and you think, well, my hands are contaminated, then they want to wash their hands. They know it doesn't make sense. They'll wash their hands till they're red, and they can't stop it. And it helps them temporarily to wash their hands to reduce that obsession, but it doesn't stop. It just keeps on going. So let's talk about the drug treatment of OCD. So when I got to Yale, it was fortunate in that numerous now world leaders were there, and they were all in the same unit that I showed up on. So I had the best mentors possible in the world, and it's really the main reason I'm here today is because of my mentors. But they were developing this scale at the time called the Yale-Brown Obsessive Compulsive Scale, the YBOCS, and you can see it categorizes the types of obsessions and compulsions that you have, and then the severity of those. And you can administer that scale over time to see if it improves with different treatments. The only class of drug that treats OCD is an SSRI, a selective serotonin reuptake inhibitor. It's the only drug that treats OCD as one drug. Like here it is. There's no other drugs that work by themselves to treat OCD. And you've heard of SSRIs. There's 7 or 8 of them. It would be a drug like fluoxetine, which is Prozac, or sertraline, which is Zoloft. There's a number of them. But they only work in 40 to 60% of people with OCD. Even though they're the only type of drug that will work, they only work in 40 or 60%. Why is that? Well, because nothing's simple. You've heard a lot today about spectrum, right? And various degrees of psychopathology. So might it be that the 60 or 40% that don't get better with an SSRI have a different type of OCD, with a different type of biology that might require a different drug treatment? Well, at the same time I was learning about OCD, David Pauls and Jim Leckman at the Yale Child Study Center were doing genetic studies of Tourette's disorder. So that's a tic disorder we're going to talk about more. But what they found is that there was a type of OCD that ran with tics genetically in the family. So there's this idea, well, maybe there's this subtype of OCD that's tic-related OCD. So let's talk about what a tic is. So I mentioned that a compulsion is voluntary. You do something. A tic is involuntary. You don't do it. It happens to you. It's non-purposeful. There's no purpose for a tic in day-to-day life. And they're rapid. They occur like this. They can be lightning fast. Many times people with tics or Tourette's disorder will tell you they feel a sensory a phenomenon before the actual tick occurs, kind of like an itch that you want to scratch. Now, people with tics or Tourette's disorder can suppress tics. So if they don't want other people to know they have tics, they can keep them under control for a little bit of time. But then what might happen is, let's say they go into the restroom and they kind of let out a flurry of tics, if you will, to get rid of that, to scratch the itch. So what's Tourette's disorder? When you hear that, it sounds like it's more severe than something like chronic motor tic disorder. And they make movies about Tourette's disorder and all of that. But it's really just a combination of tics. It means you have at least two types of motor tics. And the most common type of motor tic is repetitive eye blinking. But you could also have facial grimacing, shoulder shrugging. Those are motor tics. But you also have to have at least one vocal or phonic tic. So that might mean humming, it might mean throat clearing, nasal sniffling, or actually saying words, right? And Tourette's disorder gets sensationalized with coprolalia, when a person might say a really bad word out loud, right? But that's not that common. So then we were sort of into this thought about, well, there's at least two subtypes of OCD. There's tic-related OCD, and there's non-tic-related OCD. I guess that's when I came onto the scene. So then how do you treat OCD? Well, I mentioned an SSRI, but what about the 40 or 60% that don't get better? So this study, we took adults with OCD, we gave them an SSRI, fluvoxamine, for 12 weeks, which is long enough. And if they just had OCD and no tics, half of them got better. If they had OCD and tics, 20% got better. So there's a difference there in treatment response with regard to the phenomenology, the clinical subtype of OCD. So now we have to figure out, well, how are we going to help the people with OCD and tics get better, do better? So, well, tics. What drug do you use to treat tics? Well, these two are FDA approved, haloperidol or Haldol, Pimozide or Orap. These are drugs that treat tics, and they block dopamine. That's how they work. And you've heard of more recent antipsychotics, dopamine blockers like risperidone or aripiprazole, those kind of things. They can also treat tics. So we said, let's take people that get an SSRI for 12 weeks, and if they're not better, let's try to add a drug to the SSRI to see if we can get an improved response. So 34 adults with OCD who were not better with fluvoxamine then were randomized to receive 4 weeks of Haldol added to fluvoxamine or placebo. Is the combination better than fluvoxamine alone? And it is. So when we added haloperidol, among the non-responders, 65% then went ahead and their OCD was responsive. And when we looked at those that had OCD and tics, 100% of them were better to this combination treatment. So we were on to something here, that not only is there a different subtype of OCD, but the treatment response is different and requires a different approach. This is 1994. That's how long ago? 30 years? This is still the only add-on treatment to an SSRI that works consistently in OCD. You're like, well, what other drugs could you add to an SSRI to make them work better? There haven't been any other mechanisms that have been demonstrated since this that are any better than this. All right, that's the first half of the show. And I'm an adult psychiatrist there doing OCD. I had no interest in children, no interest in autism. And then one day, then Rain Man's in the movie, December of '88. This was a very important movie for a number of reasons. It showed society that you can be an adult with autism. So back then, if I had all of you in the room, started talking about autism, you have the image in your mind of a child. You don't think about an adult. And back then, we didn't even know there were adults with autism. It seems strange now because it's a common topic in society, but back then, it was not. When I started doing autism, the prevalence was 2 to 4 people out of every 10,000 had autism. Now it's 1 in 36. So it was rare when I started doing it and when this movie was in the theaters. So one day, I'm at Yale doing adult OCD, right? And here comes this patient, maybe he was 30, and his parents are with him, maybe they're 70. Well, that's an unusual presentation for an adult with OCD. Usually their parents don't come with them. They're function on their own. And this gentleman was sitting there like this. He wasn't looking at me. He wasn't saying anything. And I said, well, why do you think he has OCD? Well, he picks at his fingernails, and once he gets started, they start bleeding and everything. But in his mind, he then wants to fix them, make them better the way they were, so he keeps picking at them, and they only get worse. Well, that's a repetitive behavior, but is it a compulsion, right? Is he grooming his hands or taking showers or cleaning things? No, it's very different. So again, it's a repetitive behavior, not a compulsion. Maybe this is an OCD. Maybe people with autism have repetitive behavior that's not OCD. And that's kind of what the story was. So I asked my bosses, I said, how about if I start a clinic for adults with autism back then? And they're like, why not? Well, one why not could have been because I don't know anything about it. And the other is I'm not a child psychiatrist, but I wanted to do it. So that I did it. And I learned how to do autism from taking care of patients and from their family members. I opened this adult autism clinic, again, when it was rare. There's no such thing. And they came from all over the country. So we started figuring out what autism in adults looks like. Then I had to become a legitimate child psychiatrist. So here I am, I'm a faculty member. I'm busy doing OCD, and now I'm going to become a trainee again and go to the Yale Child Study Center 2/3 time over 3 years to become a child psychiatrist and understand children and development so I could really be prepared to do autism in a meaningful way. So what is autism? Well, the core disturbance is in social relatedness, as Dr. Constantino has clearly demonstrated. And many times these people don't know how to interact socially. They might or might not want to, but they don't understand how to actually do it mechanically. They can't read social cues, etc. You can also have autism and be quite social, but it's inappropriate. They stand too close. They're talking about one particular topic over and over. So it's not just a lack of, it's just not typical. And then communication. 25 to 30% of people with autism never talk their whole life. They never talk. And we have no idea why they don't talk. Well, why don't they talk? We don't know. So we're currently trying to figure that out, but we had to pair up with MIT and get into a bunch of technology to try to study what's going on in their brain when they're making efforts to communicate and things like that. But we really don't have an idea. And then these repetitive behaviors, right? So they rock, they flap their hands, they line things up, they spin things, etc. Well, that's OCD. Well, no, it's not OCD. I've already told you what OCD is. So this is a fun study, I thought. Let's take 50 adults with OCD and 50 adults with autism and see what kind of repetitive thoughts and behaviors they have. If it's OCD, they ought to be the same in both groups. Well, what did we learn? If you look on the top, it's repetitive thoughts. And you see there's a lot more hashed lines going on than in the open boxes. That's because if you can't talk, you don't know if they have obsessions because they can't tell you. So, if a third of your group can't talk, you say, well, are you thinking a lot about this or that? So you can't do it. But compulsions, repetitive behavior, you can observe it. But the types of things that they were doing repetitively are quite different. Here's OCD. Yeah, they're cleaning and checking. That's what they do. What do people with autism do? Well, they collect things. They ask questions over and over. They engage in self-injurious behavior, and they order and arrange and repeat a lot of things. So it's very different, the kinds of things that people with autism think about and do compared to those with autism. So what are we going to call these repetitive thoughts and behaviors in people with autism if they're not OCD? Well, why not preoccupation? Because that's what it is. These are different types of repetitive thoughts again. What's a preoccupation? Well, it's egosyntonic. So right away, it's rewarding. They like to think about it. It's not an obsession where it's disturbing and you want to push it out of your mind. And what do people with autism like to think about? A lot of stuff. Sharks, the Titanic, muscle cars from the 60s, different types of hummingbirds. They know everything there is to know about it. They can give you a lecture on it. So they like it, right? Now, I'm a big John Lennon fan, so nice to be in New York. And I know a lot about John Lennon, more than anybody in the room. I'm confident of that. I know more about the Beatles than anybody in the room. We can talk later if you'd like. But I like to think about it. But can a preoccupation become interfering? Well, it's sort of interfering with my presentation right now, right? And so it can. And with people with autism, they can be so focused on their thoughts that they're not engaging in things that they should be. So in a way, even though it's pleasurable, it can be interfering. Now, what's the repetitive behavior that people do with autism if it's not a compulsion? How about a stereotypy? Well, the first thing is that's a hard word to say. And it's really hard to spell. So think about that one a little bit. What is a stereotypy? Like a compulsion, it's voluntary, that you initiate it. It's not purposeful. Flapping, rocking, lining things up, spinning things. It's purposeful in the sense that it makes the person doing it feel better. They're doing it because it helps them to self-regulate and reduce their anxiety. And, you know, over the years I've learned that maybe it isn't even something that you want to try to get rid of. I mean, if you don't have that stuff, you don't get a diagnosis of autism. It has to be there. And if they're using it to calm themselves down, why would you try to eliminate it and think about it as a pathological feature? Okay. So we went back in, right? Well, if SSRIs are the only drug that treat OCD as a one-drug approach treatment, let's see what SSRIs do for repetitive behavior in people with autism. Because we already know that we think it's not OCD. Well, then if it's not OCD, maybe it doesn't respond to an SSRI. So this was the first study we did in kids with autism, 34 of them, 12 weeks, drug or placebo. Wow, 1 out of 18 got better. When in OCD, that would have been 40 or 60% of people. Very different. And what the side effects is what really drove it. Even at low doses of the drug, they became agitated, irritable. It made them worse, if you will. So a very different response to the drug you're using to treat OCD. Now, that result has been replicated numerous times now in very large sample size studies by good researchers looking at repetitive behavior in autism and SSRIs versus placebo. They're no better than placebo, and they make you worse. So I think what I've tried to tell you today is there are different types of repetitive thoughts and behaviors. People with OCD and autism have them. They're quite different, and the response to drug treatment is radically different. So back to the obsession, bottle, perfume. What would be the appropriate name for that product? rewarding. It feels good. I like to think about it. Preoccupation. I don't know if it would sell as well, but that's what, you know, tell people that that's probably what it ought to be called. Now, you know, I'm a big believer that mentors are the most important thing in your success in academic medicine. I'll talk to you, I'll argue that point with you as well, as long as you'd like. So I had great mentors at Indiana. Really the people that made the biggest impression on me and helped me the most were my mentors from Yale. And these guys have gone on to be very prominent positions, currently still here in New York City and everywhere else, and at the Yale Child Study Center. And at Harvard I've had some leaders that have been helpful to me in my career, so I'm very thankful for that. And that's it. Thank you very much. Yeah, a couple.
Questions?
He always, yeah. You're the guy we go to.
Yeah, always.
Let me get this microphone because I can't hear very well.
Okay.
Talk loud.
That was a wonderful talk. Thank you so much. Now, I deal with a lot of people. In fact, almost all my patients have psychotic disorders. And a lot of them have recurrent thoughts. And a lot of them come to me with a co-occurring diagnosis of OCD, which I don't agree with.
With people with autism?
No, I'm talking about just people with psychotic illnesses.
Psychotic disorders.
Schizophrenia.
Right.
And I use a lot of clozapine, which has been accused of causing, OCD-like thoughts. Now, do you think this is OCD, or is this psychogenic rumination, a psychotic repetitive thought? What is the mechanism, and how would you approach it?
Yeah, so that's a great question. I couldn't talk about all of the repetitive thoughts and behaviors today, but you saw delusions up there. And, we think a lot about that. People with autism can become psychotic, but no more so than you or me. Let's start with that. And people with schizophrenia, when they have comorbid OCD, if that's what it is, often are more refractory to treatment and do more poorly. So is it OCD? Well, one thing that's interesting about the OCD of schizophrenia is that when you treat psychotic symptoms of schizophrenia, you can bring on the OCD as a side effect of the drug. So then you might say, well, okay, let's give them an SSRI to dial it down. It generally, oftentimes, does not work. So that's back to this idea of, well, not everything is OCD or is going to respond to the treatment for OCD. So I think that's something the schizophrenia people can look at in a lot more detail. Here's another thing. The clozapine. So when we were looking at antipsychotics as an add-on in SSRI refractory, we looked at clozapine, and it did nothing for OCD per se. So that's kind of interesting too. But it gets to this concept of various types associated with different disorders and different treatment responses.
But in your hands, did you find it made it worse? Because that's one of the...
An SSRI?
No, the clozapine when you add...
Oh, it did? No. So that's another good point. So in schizophrenia, it can cause OCD or make it worse, right? In autism, or in OCD, it did not make it worse. It just didn't help. So there's lots of sort of clues, but we really don't understand the underlying biology. But we've learned a lot about treatment anyway.
I'm hoping that you'll report back to us as soon as you get them to change the name of that perfume.
Yeah, well, I have an appointment this afternoon to talk to Calvin Klein.
Thank you, Dr. McDougall.